This is about spinal cord and peripheral nerve pathways. Um, it's it's interesting. Often this is left till the end of any kind of teaching conference, that kind of thing. We often spend a lot of time on the brain, and then it'll be one or two sessions, and then that's it. That's the spinal cord and the peripheral nerve covered. There's actually a lot to cover. Now, most of the anatomy you can actually read in many textbooks. So I will try to keep the boring stuff to a minimum and make it slightly more interesting. Um, I've put an Albert Einstein quote here. It's probably the only quote from him that I don't agree with. He basically suggests that the spinal cord is less important than the brain. Although I am partly a spine surgeon, but this is not this is not me being opinionated. I do think that the spinal cord is as important as the brain, as you would not be able to move if you didn't have a spinal cord. Um, anyway, now this is probably what you're expecting, a talk about all the different tracks of the spinal cord. Um, I can stay on this slide for the next hour and talk to you about every single track that's listed on here, but that would be very boring. So I'm not going to dwell on this slide for too much, except just to mention a few things. Which is that there are only really a few tracks that you really have to know, both in terms of, if you're in medical school and you're doing your exam soon, or actually in terms of clinical practice, in terms of clinical relevance. The dorsal columns at the back are very, very important. You have to know about the dorsal columns. Dorsal columns obviously convey your light touch and vibration sense, and also your proprioception. And that's probably, in my opinion, the most important track out of all of them, because if you lose proprioception, even if you've got normal grade 5 by 5 power in your limbs, you will not be able to stand. You'll probably struggle to sit with good balance. You certainly would not be able to walk independently. Proprioception, which is joint position sense, is so important. And people often overlook the importance of sensation and proprioception. And you see this often, you have a patient admitted who's got a cervical cord compression, who's struggling to walk, and you see the daily ward round notes saying that, no change in power, no change in power, patient neurologically stable. But actually, no change in power does not equal neurologically stable. Their power may remain grade 5 throughout, but if their proprioception is getting worse, and actually they're falling over more and more frequently, their neurology is not stable, and this is a deteriorating patient who needs something done. When you see this all the time, especially on surgical ward rounds, because it's a business round. We try to be quick. We all want to get on and move on to theaters, clinics, whatever it is. You often see registrars and consultants just very quickly saying, lift your arms up, lift your legs up, wiggle your toes, and then they move on. Actually, sensation is probably more important than motor power. You can often work around a bit of weakness, but it's very difficult to work around loss of proprioception. So remember your dorsal columns. And then the other important sensory tract is obviously the spinal thalamic tract, which conveys your pain and temperature. And then from a motor point of view, as you know, most of the motor is at the front, which is why with people with anterior cord syndrome, they lose their motor power rather than sensation, and that's mainly your cortical spinal tracts. And we'll come back to all of this in a bit more detail in a minute. Now, the other slide that you often would see is the actual kind of arrangement of the rexid laminae within the spinal cord white matter. So you've got the dorsal horn, lateral horn, and ventral horn. Lateral horn only present in the thoracic spine, which is your sympathetic output. And you've got laminae from 1 all the way through to 10. And some of you may know some of these already. The important ones to know, you don't need to know all of them, but the important ones to know is that the dorsal horn are your sensation, and most of your sensory inputs come to lamina 2, which is substantia gelatinosa, and it's from number 2 that you have all your inhibitory interneurons, your gate control theory for pain and not the rest of it, and obviously that projects to other laminae, mainly to 4, which is your nucleus proprius, 5 and 6, which is your lateral basal nucleus and spinal reticular zone, and before it projects up towards the brainstem. Anteriorly, mainly lamina 9 is your motor nuclei. Those are the ones that you should have a bit of knowledge about. But once again, I'm not going to go into too much detail right now. The question really is, do I really need to know all of this stuff? Some of it is very interesting, but clinically possibly irrelevant. So what I'm going to try and do is divide it up a little bit. We'll go through all the sensory pathways and then the motor pathways and talk about why it's important to know about these things. Okay, so we'll start with the sensory tracts, and that obviously starts from your skin all the way up to your somatosensory area. And if you've joined my visual pathway talk previously, you'll know that I like my basic science. So this is not going to be pure anatomy. There will be some basic science behind it. So just general thing about sensation. So sensation was first described formally by Weber and Fechner in the 19th century. And they basically show that we have four main types of sensory information. And they are divided into modality, location, intensity, and timing. So these are the sensory information that's conveyed by our peripheral nervous system to our central nervous system. Okay, so by modality, I mean the type of sensation, and that doesn't have to be touch. It can be your balance, hearing, vision, whatever. Today, obviously, we're concentrating on touch and pain. And then obviously your system can locate where that sensation is coming from, and that is defined by which set of receptors are being activated. So in terms of touch, obviously if someone's touching you on the back of your hand, those are the sensory receptors activated, and the brain will know that those are the receptors activated, and therefore that's where the touch is coming from. So location is relatively easy to map out by the brain. The intensity of the touch, so are they pushing really hard, are they really just touching, is it feather, is it a cut, is it pain? There are different ways of conveying intensity, obviously different type of touch. So light touch, vibration, and pain is all conveyed by different types of neurons. So as you probably remember, you've got your A alpha, A beta neurons, your gamma neurons, your interneurons, your myelinated and unmyelinated A and C fibers as well. But also it is conveyed by the amplitude of the action potential that's going through your nerves. And that amplitude is interpreted as the intensity of the touch sensation. And finally, the timing. When I say timing, what I mean is, has someone just touched you and let go immediately, or are they continuously applying pressure on an area of your skin? And that obviously, the obvious way of conveying that information is when was the receptor activated and at what point did the receptor stop being activated. And that time frame obviously gives you the timing. But do remember there are adaptations. So you have rapidly adapting and slowly adapting fibers. And the reason for doing that is that if, let's say, you get stabbed, and obviously it's extremely painful as the knife goes in, but that level of pain doesn't persist throughout until the knife is removed. And that's because the fibers will adapt to certain levels of intensity of sensation, and they will stop firing after a while. Which is why if someone is touching you, say on your either the back of your hand, you obviously feel them touch you. But if they just kept the finger on there, after a while, unless you look, you'll probably forget that they're still touching you, and that's because your fibers adapt to it. So it's actually quite interesting. Just a little bit more about modality. How do we tell the different types of modality? That's by the different types of sensory receptors that we have. Sensory receptors are quite specialized. So for the purposes of today's talk, we're mainly talking about the mechanoreceptors, which are amongst the skin, amongst the muscles, muscle spindles, and that obviously conveys information about touch, proprioception, your stretching of muscle fibers, and also actually the hearing nerves are also activated by mechanoreceptors. Chemoreceptors is mainly about pain, itch, taste, and smell. Thermoreceptor obviously is about temperature, but not just about the temperature of the object that you pick up, but you can sense the temperature of the air around you, and you have a feeling of your own body temperature. Like if you have a fever, you feel really hot. So thermoreceptors can give you sensation of the temperature both inside and outside of your body. And then there is only one type of electromagnetic receptor in the human body, and those are your photoreceptors that allows you to see, that we talked about last time already. each of these classes of receptors are then subdivided. They're not homogeneous. Otherwise, everything will be black and white, for example. So, your photoreceptors, as you know, are divided into your cones and your rods. It's exactly the same for all these other types of receptors. They're all subspecialized so that you get submodalities. So, when I say touch, you can, even with your eyes closed, you should be able to tell the difference between someone's fingertip touching you, their fingernail touching you, a pin, pricking you, or feather, kind of just wiping your surface. You can tell the different types of touch. And that's partly related to the intensity and the timing that I mentioned earlier on, but also because different types of mechanoreceptors are being activated. And I'll show you a slide on that in a minute. And then that information is conveyed by also subspecialized axons. So the axon of these sensory receptors are also all modality specific. So it's not just that you have a different type of receptor, but the actual axon is specific to the type of sensation that it conveys back to your spinal cord, which is what maintains all the different types of sensation that you have. And obviously, several types of receptors can be activated all at the same time. It doesn't have to be one or the other, but your brain is arranged in such a way, I have one slide on that later on, so that you can still maintain all the different types of modalities simultaneously. So for example, when you say listening, I'm not talking about touch now, but if you're listening to a concert, for example, you can tell there is a string instrument, there may be, some percussion at the back, and even amongst the string instruments, you can tell there's a violin, a viola, etc. Even though all that sound is coming into your ear at the same time, and it's because all of these axons convey different information, and they're all maintained according to the different layers of your cerebral cortex and interpreted in parallel to one another. So you can tell all of these different things simultaneously. So, back to the touch mechanoreceptors. You remember this from medical school, for those of you who are no longer in medical school, and for those of you who are still in medical school, you'll remember this from your first year of medical school. There are different types of mechanoreceptors within your skin, within the dermis mainly of your skin. So superficially, these are the two types that we talk about. I hope you can see my arrow. This is your Meissner's corpuscle, and you've got your Merkel disc receptors. So Meissner's corpuscle is situated right next to one of these kind of epidermal clefts, and it is a rapidly adapting receptor, and it is very sensitive to changes to the mechanics of the skin because it's so superficial. So it is for kind of fine sensory information. The Merkel disc receptors, which, as you can see, also very superficial, but not sitting right next to a cleft, they are the slowly adapting receptors, and they sense sustained pressure. And then deeper down, you've got your Pacinian corpuscle, which is around here, and these are rapidly adapting receptors, so they're a bit like the Meissner's corpuscle. They're rapidly adapting. When they say rapidly adapting, by the way, that means that they will fire an action potential, and very quickly that action potential will dampen down, and they won't fire another one even if there is sustained pressure, which is why they're good for fine detection of sensation rather than the slowly adapting receptors, which can sustain the action potential for a longer period of time. So you'll continue to feel any sustained pressure on your skin. So Pacinian corpuscle is deeper, and it is for rapid changes to your skin indentation, such as vibration. And then finally, you've got your Ruffini endings, which is round here that you can see, and they are the deep version of the Merkel disc receptors. They're slowly adapting receptors, and they sense stretch in the skin. And they are really important because they allow you to perceive the shape of an object. So when you close your eyes and you pick up a phone, you pick up a coin or whatever it is, we all know that the parietal lobe controls the fact that you can feel what an object is, and it is one of the things you test when someone has a parietal lobe dysfunction. But the reason you can tell is because of the Ruffini endings sensing the different amount of skin stretching and indentation in the different parts of your palm, and all that information together will form the shape that your parietal lobe then puts together. And based on your knowledge of what various objects look like, so this is your frontal lobe and your hippocampus, together they will form a visual of what the object it is that you're holding. So it is quite a complex chain of reaction to know what you're holding without looking at it. I hope that all makes sense. Now, when someone actually touches you or something actually touches your skin, as you can see here, it will activate one of the receptive field of one of the neurons. And as you know, an action potential is activated and it is transferred from one node of Bronchier to the next one. As you know, this is very important with the myelination of the peripheral nerves. Otherwise, you have very slow transduction or conduction of the signals. By each node of Bronchier, you've got a sodium-potassium ATPase that allows reactivation of the next action potential. And so you basically jump from one node to the next and really speeds up your conduction of the signals. But you've basically got retrograde conduction of the signal back to the cell body, and then the antigrade movement of the signal to the dorsal horn of your spinal cord. Which is what I've written here. Now, the intensity, which is what I was talking about in terms of the amplitude and things like that, it is governed by this interesting law called Weber's law. Now, I'm not expecting you to know the equation. I'm certainly not going to go through the equation. The only reason I've mentioned this is that you're only able to tell certain types of differences in terms of intensity. For example, if I gave you something that's 1 kilogram to hold in one hand and something that's 2 kilograms to hold in the other hand, you will immediately notice a difference between the two. But if I gave you something that is 50 kilograms in one hand and 51 kilograms in the other hand, you will not be able to tell there is a difference between the two, even though both examples there is a 1 kilogram difference, and that is called the just noticeable difference, which is the constant K. So there is a way to calculate what you're able to differentiate or what you're not able to differentiate when it comes to the intensity of a touch sensation. Anyway, like I said, I'm just throwing this in because I find it very interesting. You may think it's irrelevant. Now, once your signal goes to the spinal cord, it doesn't just get conducted directly up to your brainstem and up to your thalamus and parietal lobe. Actually, the signal gets modulated before it is transduced upwards. And pain is the best example, which is why I've put pain modulation here. So with pain modulation, there is something called gate control hypothesis, and there are two parts to this. The first is the ascending pathway. So you've got your input from your nociceptive receptors from your skin. So these are sensory receptors specialized in pain, and you've got the non-myelinated C fibers and your myelinated A alpha fibers. Okay, and these go from your skin all the way up to your spinal cord. They enter the dorsal horn, as I said earlier on, into lamina 2 or substantia gelatinosa. There we have inhibitory interneurons. Okay, and whether the inhibitory interneurons are activated or not would depend on what is the intensity of the signal coming through your pain pathway, which is your C fiber, and the signal coming through your normal touch pathway, which is your A beta fibers. Essentially, if you've got lots of activation of your C fiber, so lots of pain and very little touch, then what happens is you will directly activate the inhibitory interneuron, and that will dampen down your response. And that is present to make sure that you will never experience pain that is too much for you to cope with. Okay. Whereas if you've got activation of both the pain and the non-pain peripheral nerve, then you won't have activation of the inhibitory interneuron, and you will have a normal sensation going through as what it should be, because you've already got that mixture of pain and non-pain sensation coming through together. So that's the ascending pathway. It is basically the inhibitory interneurons within the dorsal horn that either inhibits or doesn't inhibit the outgoing path that goes up the rest of the pathway towards your brainstem. There is a descending pathway that comes back down the other way from the periaqueductal gray matter. Now, this is activated by the spinal reticular, the spinal tactile tract, which I will come on to in a minute. So when you activate a sensory receptor, as you all know, you've got your touch, vibration, sense, and proprioception being conveyed up your dorsal columns, and you've got your pain and temperature conveyed up your spinothalamic tract. But at the same time, all of this information is also being conveyed up through your spinal tactile tract to the tectum area, and it ends in the periaqueductal gray matter, where the signal is being analyzed. And if it is deemed that the pain signal is too intense, it will then activate the PAG, which sends descending path all the way back down to the spinal cord via the raphe nucleus, essentially to inhibit these pain pathways, so it dampens down the amount of pain that you are feeling. And as I've written here, the projection is via the serotoninergic nuclei, which is your raphe nucleus, and the noradrenergic pathway, which is your locus coeruleus. So these come back down as the gate control descending pathway to dampen your pain sensation. So there are two pathways, the local interneurons, which are inhibitory, and the descending pathway from the periaqueductal gray matter, which is activated by your spinal tactile tract. Both of these will modulate the signal before the information is then transduced all the way up to the thalamus, where it then goes to your somatosensory cortex. So the information that's actually received by your brain is modulated. It's not the pure information that you would expect from whatever the stimulus is. So this comes back to my point about Albert Einstein's quotation that, he said that, these people who are arrogant obviously have too big a brain, and actually they should just have a spinal cord. But actually the spinal cord itself already does signal modulation. There is already, if you like, thinking within the spinal cord. So the spinal cord is a lot cleverer than you think it is. Back to the actual pathways, there are two main ascending sensory systems that you need to know about. So once you've got all that sensory information from the sensory receptors through the peripheral nerves into the spinal cord, they go up either the dorsal column medial lemniscus pathway or the anterolateral pathway. Okay, so the dorsal column medial lemniscus pathway is very simple. It's your touch, proprioception, and your vibration sense. You have axons that go up the dorsal column on the ipsilateral side of where the sensation is perceived, all the way up to the medulla. Okay, and in the diagram you can see the fibers coming into the dorsal horn, as I said, with a signal modulation here, and then it goes into the dorsal column. You have two bits to the dorsal column, as you may remember. Medially, you have your fasciculus gracilis. Laterally, you have fasciculus cuneatus. I think I might have it here. Yeah, that's right. So the medial pathway comes from your lower limbs and your lower body, so lumbar and lower thoracic regions. Your fasciculus cuneatus, the more lateral bit of the dorsal column, comes from your upper body and your arms, going upwards. So that's the topographic arrangement, and that's quite important to know because it does change sometimes the patient's presentation. You may wonder, why is the patient only numb in certain parts? Is it possible that the patient has a spinal cord lesion that gives them arm numbness without leg numbness? Yes, it is, because if they specifically affect that part of the spinal cord, it's very difficult to. But if you do, then you can get exactly that symptom. So knowing this anatomy helps you diagnose what's wrong with the patient. But essentially, the pathway ascends in the dorsal columns on the ipsilateral side to the stimulus, all the way up to the medulla. Okay, in the medulla, that's where it decussates. So in the medulla, it will cross to the other side of the brainstem and join the tract that is called the medial lemniscus. And it goes up the medial lemniscus into the ventral posterior lateral nucleus, or the VPL nucleus of the thalamus. That nucleus is where essentially all your sensory information converge to, whether it's pain, whether it's proprioception, whether it's touch, they all come into the VPL nucleus. And it's from there that then you have your second order, or actually it's the third order neuron from the thalamus going up to your somatosensory cortex. So this is the dorsal column, the ipsilateral dorsal column, and then contralateral medial lemniscus pathway of conveying touch, proprioception, and vibration sense. The anterolateral system, on the other hand, is slightly different. You have your unmyelinated neurons, which are much smaller in diameter, and they come together to form your Lesueur's tract, which then goes into the dorsal horn of your spinal cord, as we said before, lamina to substantia gelatinosa, where your gate control theory is. And then within the lateral horn, the dorsal horn, you have pathways that project into some of the other lamina, which is also still part of your kind of signal modulation. So we won't dwell on that too much, but essentially it then crosses the midline to join the spinal thalamic tract on the opposite side before ascending on the opposite side of the spinal cord up to the brainstem. Okay, so the spinal thalamic tract, or actually I should say the anterolateral system, decussates within the spinal cord. Now, the only thing to say that doesn't show on this diagram is that the decussation doesn't occur horizontally at the level of the stimulus. It actually occurs at an obliquely going upward manner. So let's say you have stimulation of your L5 nerve, for example. The sensation comes in at the L5 level, but as it decussates across to the opposite side, it actually starts to ascend. So it may not reach the spinal thalamic tract on the opposite side until it gets to about L3 or even L2, which is why when you do injure your spinal thalamic tract, like in the Brown-Séquard syndrome, often there is some loss of pain and temperature sensation on the ipsilateral side as well as the contralateral side, because the ascending tract does not go horizontally. So just be slightly wary of the sensory level and thinking, why does that not match up with the level of the injury? And it's because decussation is not horizontal. So the spinal thalamic tract conveys your pain and temperature all the way up to brainstem. The second anterolateral system is your spinal reticular tract, which also decussates along with the spinal thalamic tract, goes all the way up, but it ends in the pons and the medulla. It doesn't go to the thalamus at all. The spinal thalamic tract, just like the dorsal columns go to VPL nucleus, spinal reticular tract ends in your reticular formation. And it is for the memory of pain and your emotional response to pain. That's the kind of information that this tract is conveying up to the brainstem. And then finally, as we mentioned before, you have the spinal tactile tract, which goes up to the periaqueductal gray, which is part of your descending gait theory. Just in a little bit more detail, just to show you, spinal thalamic tract on the left-hand side, crossing in the spinal cord, ascending here in the lateral spinal thalamic tract, medulla, and then into the pons, and then up to the VPL nucleus of the thalamus. The spinal reticular tract follows the spinal thalamic tract, but when it gets to medulla, some of it ends in the reticular formation of the medulla, some of it goes up to the reticular formation of the pons. And then you have the projection neuron from the reticular formation up to the thalamus before it continues to the rest of the brain. And then you've got the spinal tactile tract, which goes all the way up to the tectum or periaqueductal gray area, activating a descending pathway that controls the amount of pain information that's allowed to ascend through your spinal thalamic tract. So these three tracts together forms your anterolateral system. Okay, so that's all the sensory things you need to know. Your sensory receptors, basically mechanoreceptors, your neurons that goes from whichever parts of your body to your dorsal horn of the spinal cord, your interneurons and your descending pathways that modulate the signal, and then the ascending pathways, which is either the dorsal column, contralateral medial lemniscus system, or is the spinal thalamic, spinal reticular, and spinal tactile system that forms the anterolateral system going up on the contralateral side of the body. Okay, I hope that makes sense. So that's the system, and this is just showing the rest of it. This is not really part of this talk, so I won't talk too much about it, but this just shows what happens when you get to the top. You have the VPL nucleus. I think I have a better, yeah, that's it. So you have the VPL nucleus of the thalamus. It then goes to your somatosensory cortex. As you know, it is the first part of your parietal lobe, just behind the central sulcus. In terms of Brodmann area, you've got 3, 1, and 2, 3A, 3B, 1, and 2. That's your primary somatosensory cortex. And just remember, the somatosensory cortex, if you look on the coronal slide, comes all the way along the sylvian fissure as well. So there is some sensation at the back part of the sylvian fissure. And then the actual somatosensory cortex, just like the visual cortex that I talked to you about previously, is divided into lots of different layers and columns. So we've got 4 Brodmann areas, as we said, 3A, 3B, 1, and 2. each of these Brodmann areas will receive from a different part of the body. So for example, your fingertips go directly to Brodmann area 3A. Each of these Brodmann areas is then divided into the slowly adapting and the rapidly adapting columns, and each column is divided into 6 layers. And it is the complex column and layer structure of the somatosensory cortex that allows the retaining of the different information from different types of mechanoreceptors, different information being conveyed, the intensity, the timing, all of that is conveyed to all these different layers. And then the frontal lobe obviously helps to amalgamate all of this information together that then gives you the information that you perceive as touch, pain, vibration, whatever it is. So it's all very complex. Anyway, I think that's enough about sensation. I shall move on to motor tracks. Okay, so this time we're going to start at the top and work our way back down because motor systems are descending pathways. Okay, so movement, firstly, you need to initiate your movement, and everyone knows about the primary motor area, which is your precentral gyrus. You've also got the supplementary motor area, which is just in front of the motor area. But remember, to initiate movement, your motor cortex doesn't suddenly just send a signal to your arm and make it move. If it does, then you've got a seizure, right? It is all controlled. You have to think that I want to move the arm before the arm moves. So actually, it is your higher cognitive areas within your frontal lobe, as well as all the sensory information that you have perceived from your somatosensory cortex that feed into your motor area that ultimately initiate the response of moving something. Okay, and then that signal is further organized by both feedback and feed-forward mechanisms from the cerebellum and the basal ganglia. You've had talks on both of these areas before. I'm not going to talk about them at all. It's just to let you know this all feeds together into the same system. And then you've got a signal that comes down from your motor area through your internal capsule, down your brainstem as your cortical spinal tract. Now, there are different types of movement that we can talk about. You can talk about the voluntary movement. You can talk about simple reflexes. You can talk about the control of posture. You can talk about locomotion. There's lots of different things. Once again, that's a separate talk altogether. If anyone's interested in basic science, I can give you a 2-hour lecture about different types of movement and muscle units and things like that, but it's not part of this talk. But the main thing to know is that all of this information from the motor areas feeding down to the brainstem comes down 2 separate systems. We've got the medial and the lateral descending systems. The medial descending system include information from your visual, vestibular, and sensory cortices, and it's mainly important for the control of your posture and your balance. The lateral descending system goes down to your limb muscles and is your voluntary movement. Okay, and that's why when you look at a cross section of a spinal cord, often you'll see a ventral and a lateral cortical spinal tract. So the medial one, which is the ventral cortical spinal tract, is actually control of your posture. The lateral cortical spinal tract is your control of actual voluntary movement. Okay, and then you've got the reflexes, which are mainly simple monosynaptic arcs within the spinal cord that doesn't involve the cerebrum. Although a lot of these reflexes do have some input from the cerebrum in terms of inhibition or further excitation. So once again, feedback, feed-forward mechanisms, not part of this talk. So just a quick example, this is the medial brainstem pathway coming down from the cerebrum that isn't shown at the top of the picture. And it basically goes down to the, goes into the tectal area, projects to a reticular formation affected by your vestibular nuclei. So as I said, this medial pathway converges all the information from your visual, vestibular, and somatosensory pathways to get all of the information and feeds down to your ventral cortical spinal tract, as well as the vestibular spinal tract and reticular spinal tract that controls your posture. So if you're wondering what all of these extra tracts do, they're all part of posture control, and all of them converge together. And then the other pathway, which is the more lateral brainstem pathway, comes down this way. It still gets some information from the reticular and vestibular nuclei, but mainly it is just your motor pathway coming straight down, and that's the actual control of your limb movements through the internal capsule, as we said. So you have now got information coming through the brainstem down into the spinal cord. This is what you've actually asked me to talk about, which is spinal cord. So down in the spinal cord, in terms of motor, we've already said that in the ventral horn of your spinal cord. So this is lamina 9, and to a certain extent 10 as well, but mainly lamina 9. Firstly, to note is the topographic arrangement. Can you see how the distal limbs are lateral and the proximal limbs are medial? This is opposite to what I told you about the dorsal column. In fact, out of all the tracts in your spinal cord, the cortical spinal tract is the only one organized with your arms medially and your legs laterally. And this is why in people with central cord syndrome, their arms are affected more than the legs, because the medial part is affected more than the lateral part. So this is very relevant anatomy that you should know. Okay. So once again, you've got two main nuclei in the ventral horn of the spinal cord. You've got the medial nucleus, which is basically your ventral cortical spinal tract, and it goes to your posture and your trunk control, as we mentioned before. There are lots of different theories as to how the control actually works. I won't go into too much detail, but these are the two main theories if you want to know. Essentially, it's all related to how these tracts interact with the cerebellum, and the fact that you have something called long-term potentiation with nitric oxide as a second messenger within the cerebellum. Ito thinks that the teaching line is within the climbing fibers going into the cerebellum. Myers-Lisberger hypothesis is that the teaching line, or I should say the memory, is within the Purkinje cells that are coming out of the cerebellum. Anyway, you can read up about that if you're really that interested. You then have the lateral nucleus, which is your lateral cortical spinal tract, and that is for your voluntary control, which is what we said. And remember, once again, the topographic arrangement. So you've got the information here, and then it exits, obviously, along your spinal nerve to the muscle fibers. Okay, and each nerve obviously innervates a certain section of a muscle unit to allow it to move. So this is what this picture basically shows. I've put up pictures of reflexes just because I thought I should just briefly mention it, but it definitely is not part of this talk. But as you probably know, there are two main types of reflex. You've got the stretch reflex, which is a very simple single synapse, two neuron system. So this is your tendon hammer. You hit your biceps tendon, for example. You activate the muscle spindle, which sends signal to your spinal cord that activates the next alpha motor neuron that makes your muscle contract, and that's how you get your muscle jerk. On the other hand, you've got something called the flexion and cross extension reflex. This is slightly more complicated in that activation of the muscles in one compartment, whether it's flexors or extensor, causes activation of the counteracting compartment in the opposite limb. So if you activate the flexor muscle, say in your right leg, this arc will activate the extensor muscles in the left leg, and the whole point of this is you don't fall over. So for example, your right leg steps onto a pin, you have this reflex which automatically makes you withdraw that right leg away from the pin, so your flexor muscles are being activated in your right leg. This arc allows you to then activate the extensor muscles in your left leg so that your left leg stays on the ground and you can still stand and you don't end up flying off because both of your legs have suddenly flexed and you've jumped away, basically. So this is an important arc to think about and remember. But both of these, as you can see, do not really require any cerebral input. This is purely a spinal cord reflex. And the main reason I wanted to talk about these reflexes is that when you're assessing somebody's spinal cord function and their conscious level, it is very important to distinguish a spinal reflex from a cranial reflex. So, if you've got someone who is unconscious in front of you and you go and squeeze their fingers and they withdraw from you, that does not mean they score a motor of 2 or 3. That means that they've got an intact spinal cord with an intact monosynaptic reflex arc. It has absolutely nothing to do with your brainstem or your cerebrum at all. Similarly, rubbing the sternum does not activate your brain. So I do not want to ever see anyone trying to test GCS by squeezing someone's fingers or rubbing the sternum. It is a load of rubbish. Okay, what you do is you create pain along a cranial nerve distribution. So you can squeeze the trapezius for 11th nerve. You can press on the supraorbital rim to activate the trigeminal nerve. But either way, you need to activate something that is above or from the brainstem up to test someone's consciousness. If they are not conscious, and you're also worried whether they've got spinal cord injury, of course, you can also test all of these spinal reflexes to see at what point you start losing your spinal reflex. And then you can also say this is the level of spinal cord injury. And that's how you assess someone's for spinal cord injury if they're unconscious. I hear a lot about patients, unconscious. I can't do a neurological exam. We can't do an Asia chart. We have no idea if they've injured the spinal cord. Well, you can do reflexes. You can get tendon hammer out. You can go and, you can do the Babinski. You can do your ankle, your knee. You can do a cross adductor reflex using adductor magnus muscle. You can then do your abdominal muscles if you want. You can do your brachioradialis, biceps, triceps, Hoffman reflex. And if all of these are lost, you can keep going up. You can then do a deltoid reflex, which is C5. If that's also lost, you can do a pectoralis major reflex, which is C4. And then above that is your jaw jack, which is trigeminal nerve. If everything's lost apart from the trigeminal nerve, then they've got a spinal cord injury somewhere between C1 and C4. So you can test someone for spinal cord injury purely based on spinal reflex, but you cannot say that they are conscious or they have whatever motor score on the GCS because they are able to have a reflex. So just make that very clear in your mind. So those are the sensory and motor pathways. And by knowing that, you will now be able to work out what happens when people have all of these different incomplete spinal cord syndromes. So anterior cord syndrome is very simple. It is the anterior half of the spinal cord that's taken out, and it's usually as a result of a loss of the anterior spinal artery supply to the spinal cord. I think last week's talk already covered the vascular supply to the spinal cord, so I won't go into much more detail, but essentially the way these people present is that they have weakness, obviously, because you've lost your corticospinal tract. But remember, they will also lose balance sitting up because they've lost their truncal control as well. So it's not just about being paralyzed. They are unable to sit without support. And they will also have some dissociated sensory loss. I say dissociated because the dorsal column is intact. It's the spinothalamic, spinal reticular, and spinal tectal tracts which are lost. So you've lost pain and temperature sensation bilaterally, but you've retained light, touch, vibration sense, and proprioception bilaterally. But they are often also gray zero power in their arms and legs, or wherever this level of injury is. The prognosis is very poor because this is essentially a stroke of the spinal cord. The next one is the central cord syndrome. This is most common in elderly people. They are in people who have existing osteophytes from degenerative disease, usually in the cervical spine. They fall over, they hit their forehead usually because they're elderly, they don't protect themselves because their reflexes are a bit slow. They hit the forehead, they suddenly extend the neck. What happens when you extend your neck? Your ligamentum flavum, which was taut in a normal position, as you extend, they buckle into the spinal canal. If you've already got wear and tear and degenerative changes, and your spinal canal is already narrowed, and your spinal cord is already a little bit pressed on by this osteophyte, as soon as you suddenly extend your neck and your ligamentum flavum buckles in, that basically then pinches the spinal cord, and that squeezes the spinal cord front and back and causes injury in the middle of the spinal cord. So that's the central cord syndrome. And so they will have a combination of motor and sensory loss. But remember, because your corticospinal tract is arranged different to your sensory tracts, with your arm fibers medial and leg fibers lateral, these people are weaker in their arms than they are in the legs. Okay, so that's really important to remember. Conversely, from a sensory point of view, they're worse with the lower segments, so usually the sacral segments, compared to the arm segments. So when you examine these people, they may be grade 2 power in the arms, but grade 4 power in the legs. But when you test the sensation, they've got loss of sensation in the feet and in the perianal area, but they may have quite normal sensation in the hand. So the two is actually opposite to one another. The prognosis generally is quite good for central cord syndrome, and most patients do recover some form of walking with aid or with assistance. And the sphincter control often recovers over time as well. So central cord syndrome is not too bad. Brown-Séquard syndrome, I think this is the one that every single medical student knows about. It's a hemisection of the spinal cord. It is extremely rare. I don't know why they bother teaching it in medical school, apart from to demonstrate the fact that some tracts decussate in the spinal cord and some don't. But it's very rare. The only time you see a Brown-Séquard syndrome really is when someone stabs a patient and it happens to take out half the spinal cord, which I have seen 4 of since coming to work at Imperial College. I have never seen one during the whole of my training previously. So there is something about Paddington that people like to aim for half your spinal cord when they stab you, for whatever reason. Now, if you think about it, your dorsal columns go straight up and does not decussate until they reach the brainstem. Similarly, your corticospinal tract has already decussated in the brainstem before coming down the spinal cord. So when you take half the spinal cord, your dorsal columns and corticospinal tract will be affected on the same side. So you have ipsilateral motor loss and you have ipsilateral light touch, vibration sense, and proprioceptive loss. But because of the decussation of the spinothalamic tract, you have contralateral loss of pain and temperature. Okay, so, and this is why when you examine a patient, at least when you're doing your first clerking of an admission, you should test both light touch and pinprick sensation, because unless you do light touch and pinprick sensation, there is no chance that you'll be able to pick up this difference in the sensory loss. Okay, so it's really important you test both of them. And then very rarely you can get posterior cord syndrome, which just affects your dorsal columns. And these patients are terrible. You examine them, they've got grade 5 power everywhere. Their reflexes are intact usually, but they can't walk, they can't stand, and you just can't understand what the problem is. And it's because they've lost the proprioception. But it's very rare to get pure dorsal column loss, to be very honest with you. This is a picture to show the different types of spinal cord syndromes that we've mentioned. If you've got glove and stocking distribution, then obviously we talk about purely peripheral nerve problems. So a peripheral neuropathy, diabetes, Guillain-Barré syndrome, CIPD, that kind of thing. If you've got complete loss of sensation motor below a particular level, that's obviously a complete transection of the spinal cord. Cord equina lesions, as you know, mainly affect your sacral segments, and then we've talked about Brown-Séquard, and occasionally you can get a random patch of the body losing sensation, and that's mainly related to syringomyelia. So if you've got syrinx, which is a fluid-filled cavity within the spinal cord, you will affect those particular segments, but not necessarily the segments below it. So you can have completely normal limbs, but an abnormal part of body in the middle. And this is the other thing. I often see people doing sensory examination. They test the sensation in the legs, they test the sensation in the arms, and then that's the end of sensory exam. Well, what happened to the chest and the abdomen? You can't test the motor function in those areas, so it's even more important that you test the sensation in those areas. Otherwise, you have no idea what's happening to the thoracic nerves. Okay, so always remember to test sensation all the way up. And the best kind of dermatomes to use once you've come up beyond the legs is that the umbilicus is T10, the costal margins is T8, and obviously nipple line is T4. So those are the areas that you really should test. Everything okay so far? We've got 10 minutes left. So the last 10 minutes, I'm going to tell you everything you need to know about peripheral nerves. Okay? Firstly, brachial plexus. This is the diagram that I drew this morning to try and show you how to draw a brachial plexus. If you can't draw it as quickly as this, you need to keep practicing. So I did this morning. Okay? So brachial plexus comes off your 5 nerves in your cervical thoracic spine, C5 down to T1, okay? So you've got 5 nerve roots. The top 2, C5 and 6, join together to form your upper trunk. C7 continues by itself to form your middle trunk. C8 and T1 joins together to form your lower trunk, okay? And then each trunk divides into an anterior and a posterior division. Okay, so you've now got 3 lots of anterior divisions and 3 lots of posterior divisions. And the important thing to remember here is there are no branches that comes off the divisions, okay? You have branches coming off the roots, coming off the trunks, and coming off the cord, obviously, but there are no branches off the division. Now, the 3 posterior divisions will join together to form your radial nerve. Okay, so that bit is easy. Your 3 anterior divisions, however, are slightly more complicated in that the top 2 anterior divisions join together to form your musculocutaneous nerve. The bottom division continues forward to form your ulnar nerve. But then those 2 cords each will contribute towards your median nerve. So your median nerve is formed by every anterior division, whereas your musculocutaneous nerve is only formed by your upper 2 divisions, and your ulnar nerve is only formed by your lower anterior division. And your radial nerve, as I said, is formed by all 3 of your posterior divisions. So those are the main output from your brachial plexus. Obviously, if you like, you can add in other things. So C5, 6, and 7 gives you the long thoracic nerve of Bell that goes to your serratus anterior muscle. You've got your suprascapular nerve that comes off the upper trunk, as you can see. You've got subscapular nerve that comes off your posterior cord. The posterior cord also gives off your thoracodorsal nerve that goes to your lat dorsi muscle. And then you've got all your other sensory nerves and pectoral nerves that I have not put on this diagram, otherwise it becomes too busy. So this is what it would look like if you drew it very nicely. I'm not an artist, so I'm afraid my schematic diagram does not look quite as pretty as this, but it basically says everything that I've said. I'm not going to go through it again. The main thing I want to talk about are the A, B, C, and D that's marked in here. So brachial plexus or parts of the brachial plexus can get injured that will give you different types of symptoms. Okay, if you injure at the upper trunk, you get something called Erb's palsy. I'm sure you've all heard of Erb's palsy, and the typical textbook description of someone with an Erb's palsy is waiter's tip. You know, they've got this basically hand that kind of curves around, a bit like a waiter asking you for a tip, and that's mainly because you've lost your musculocutaneous nerve and parts of your median nerve function. If you injure your lower trunk, then you mainly get something called Klumpke's palsy, which is a bit like having a ulnar nerve injury. So you end up with a clawed hand with a lower trunk injury. So that's Klumpke's palsy. If you injure your posterior cord, obviously you basically take out your radial nerve. So you end up with a wrist drop because your radial nerve governs most of your extensor muscles, so you end up with a wrist drop. If you injure all these separate nerves, I'll come to in a minute, you get different types of injury patterns as a result of the type of muscles that are being innervated. So going through them slowly, on the first diagram, you've got musculocutaneous nerve and median nerve coming down. Once again, I'm not going to go through every single branch that you see here. But the important thing here really is the musculocutaneous nerve supplies your biceps muscle, as you can see here. And a lot of people forget that. People remember the biceps muscle is innervated by C5, C6, but people forget the name of the nerve. So musculocutaneous, which is actually the main output of your upper cord. So don't forget that. The median nerve that takes a bit of everything, basically from all 5 nerve roots, comes all the way down. It supplies basically everything in your flexor compartment, from your pronator teres to all your flexor muscles, flexor digitorum superficialis and flexor digitorum profundus, as well as all your thenar muscles apart from adductor pollicis. So every movement of your thumb except for adduction of your thumb is governed by the median nerve. Most common place for median nerve problem, as you probably know, is carpal tunnel, and I'll show you about carpal tunnel syndrome in a minute. But if you do examine someone's median nerve, I mean, when we examine peripheral nerves, we always start distally because it is the easiest to test all the movement in the fingers. So all the relevant movement for the median nerve, which is all your thumb movements apart from adduction, basically. But if you found all of them are weak, firstly, it's unlikely to be carpal tunnel syndrome because the motor branches, as you can see, mainly comes off before it enters the carpal tunnel. So if all those muscles are weak, then you really should be testing the flexor compartment. And the easiest one to test is pronator teres. So you can just hold the patient's hand like you're shaking the hand and ask them to turn or pronate against you. And if that's weak, you know your injury is above the elbow. Okay, so because the branch pronator teres comes off at the elbow. So that's what I normally do. I test all the thenar muscles. If they're weak, I automatically test the pronator teres. And then if that's weak, there's no need to test all of these because you know the lesion is somewhere up here already, straight away. So that's the easiest way of testing the median nerve motor function. Sensory function, I'm sure you all know, is the 3.5 fingers on the median side or radial side, if you like. The ulnar nerve, as you can see here, comes behind the epicondyle of the elbow and then supplies some of the flexor muscles as well as DCU, flexor carpi ulnaris. And it goes to the adductor pollicis, the only thenar muscle not supplied by the median nerve, and all the small muscles of the hand, the lumbricals and the interossei. And it's very important for your abduction and adduction of your fingers. And the best test for ulnar nerve is a Frohman's test, which is where you ask the patient to hold a piece of paper between the thumb and the fingers and you pull against them. And if they've got a weak adductor pollicis muscle, so they can't squeeze the piece of paper between the thumb and the index finger, they end up flexing the thumb. So you see that thumb bend upwards. So that's a positive Frohman sign. Automatically, you know there's an ulnar nerve lesion. The other thing to see here is that there is something called the ulnar paradox, which basically is that usually you would have expected that the further away the injury is, or the closer the injury is, the more problems you're going to get. So, for example, if you have an injury up here, surely you have more neurology than if you have an injury down by the wrist, because you've affected more branches. But people with an injury to ulnar nerve at the elbow, they don't have any deformities. Whereas if they have an injury at the level of the wrist, they come to you with a claw hand. And that is really dramatic when you see someone with a claw hand. And that's the paradox in that you look at that and you think that's terrible. Actually, that is a good sign in that all the flexors are working. The problem when you injure at the wrist level for the ulnar nerve is you lose all the lumbricals and interossei, so you lose the ability to extend your fingers. But your flexors are working, so there is nothing opposing them, which is why they end up with a claw hand. When you injure the ulnar nerve at the level of the elbow, you lose all the flexors, so they don't claw their hands because all the fingers are weak in both flexion and extension. So neurologically, it is actually worse. But when you look at them, it doesn't look as bad because they don't have a deformity. So that's called the ulnar paradox. So just something to think about once again. And then finally, the radial nerve, the main thing to say about the radial nerve is that it goes along the spiral groove of the humerus, so any mid-shaft humeral fractures potentially can take out the radial nerve. So if you ever see a patient with a humerus fracture, always examine the radial nerve. Look out for wrist drop because they've lost all the extensor muscles. So very quickly, carpal tunnel is basically the tunnel beneath the flexor retinaculum that connects across the carpal bones. And this is a cross section. As you can see, you've got the tendons underneath, carpal bones right at the bottom, and you've got the median nerve just above it. So if you were ever to do a carpal tunnel decompression, you're basically freeing up the flexor retinaculum. You're cutting through this ligament to open up the space for the median nerve. On the other hand, with ulnar nerve, usually the problem is the cubital tunnel syndrome. The cubital tunnel is basically the tunnel within the ligament around the epicondyle of the elbow. So to decompress that, you'll be opening up the cubital tunnel. Occasionally, you have to remove part of the medial epicondyle. You may even have to transpose the ulnar nerve away from that site to reduce the amount of compression on it. But this is the area that you're looking at mainly for ulnar nerve problems. The ulnar nerve also goes through the Gideon canal further down here, but it's very rare that you have to end up decompressing that. And then finally, very quickly, lumbar plexus. So that's from T12 down to L5, and obviously you've got the lumbosacral plexus lower down. T12 continues on its own and becomes your subcostal nerve. Nothing too exciting about that. The L1 nerve also continues on its own and gives you the ilioinguinal and iliohypogastric nerves that basically is the sensation along your groin. Now, the L1 and L2 also join together to form your genitofemoral nerve, which is also sensation along your groin area down towards your scrotum, but not quite as far down as your scrotum and perineal area, because that's obviously sacrum. And then L2, 3, and 4 are a bit more complicated. L2, 3, and 4, they join in various ways. So firstly, L2 and 3 join together to form your lateral cutaneous nerve of the thigh. So that's sensation to the lateral parts of your thigh. L2, 3, and 4 together also join to form two nerves. One comes forward as your femoral nerve down the front of your thigh, and the other one join slightly further back as your obturator nerve, as you know, that goes down towards your pelvic areas. So that covers T12 down to L4. And then L4 and 5 join together to go down to join the sacral plexus, so S1 to 4, and all of those join together to form your tibial nerve and common peroneal nerve, which essentially are your sciatic nerve. So here is the proper diagram that shows some of that. You've got your L1 to 5 nerves coming down. You've got your femoral nerve coming this way, and you've got your obturator nerve going further back. And then L4-5 joins the sacral nerve roots to come down as your tibial and common peroneal nerve, which is together forming your sciatic nerve. This is your obturator nerve, which is the thinner one that goes on the inside of the pelvis as compared to the femoral nerve that comes on the outside of the pelvis. But both of these nerves come from your L2, 3, and 4 nerve roots. Okay. And then this shows what happens to the sciatic nerve as it goes further down. As you can see, it goes behind the knee joint, as you probably know, before it then divides to form your separate tibial and common peroneal nerves. And then obviously you have your separate anterior tibial nerve, you have your musculocutaneous nerves like you did in the arm, and then you have your medial and lateral plantar nerves that supply sensation to various parts of your foot. The most important thing to talk about here is really examining the ankle. So it's very easy to do ankle dorsiflexion, ankle plantar flexion. And most people would tell you if you're weak in dorsiflexion, you've probably got an L4 problem. If you're weak in plantar flexion, you've probably got an S1 problem. And if your extensor hallucis longus, EHL, is weak, that's an L5 problem. That's all well and good, except let's say you MRI the spine and it's all normal. Then why have they got a foot drop? And suddenly everyone's like, oh, I don't know. Well, how about trying to test inversion and eversion of the ankle? That's not something I see done commonly in neurosurgical practice, but it's actually really important. Every time you see someone with weakness of the ankle, you must test all four movements: dorsiflexion, plantar flexion, inversion, eversion. If you have a true L5 problem, you lose your EHL and dorsiflexion and inversion. If you have true S1 problem, you'll lose your plantar flexion and eversion. But if you've got different combinations, so you're losing eversion with your dorsiflexion, you've actually lost your peroneal nerve. Okay, so it's really important to distinguish whether it's coming from the spine, L5-S1, or whether it's coming from a peripheral nerve, mainly your common peroneal nerve, because obviously the treatment is completely different. Right. Summary. I think I've talked a lot and there's a lot of information. I'm sorry I've rushed through a lot of it, but it's quite hard to fit everything together. But these are the kind of salient practical points. Firstly, sensation and motor are interlinked and must be considered together. You must not say someone's neurologically intact after just examining one or the other system. And as I said many times, someone with no weakness can still be wheelchair bound because of loss of proprioception. Spinal reflexes, as I said, are monosynaptic arcs, which cannot be used to test the brainstem or higher functions. The spinal cord pathway anatomy is quite important to understand all the different partial spinal cord syndromes that I've explained to you earlier on. And most important thing, you can never learn too much, so keep reading. That is the end of my talk. Any questions? I'm going to stop share.
Thank you very much, Mr. Tsang. That was excellent, very comprehensive, and I'm sure everyone learned just as much as I did. If anyone has any questions for Mr. Tsang, please just unmute or raise your hand and we can help. Mr. Tsang, do you have the QR code at all for feedback?
Oh, that's a good point. No, I don't. Sorry. I always forget.
Lana, do you have it?
Yeah, just gonna share it right now. Give me a sec, guys.
Thank you. And if everyone on the lecture can complete the feedback, please, from Mr. Tsang, that would be great, and it also helps towards certificates as well. I don't see any hands raised, but feel free to ask it. Oh, there's one hand raised. 2 seconds. Yep. Eleonora?
Yes, hello, and thank you very much for the great presentation. I wanted to ask if it's possible to see again the first slide with the title of the presentation, mainly for the feedback.
Oh yeah, sure, of course. It's just spinal cord and peripheral nerve pathway. That's all it is.
Okay, thank you very much.
The feedback form is quite specific anyway, so I don't know if you need to include the title, I don't believe.
It was a great lecture, Mr. Tsang. Thank you so much.
Yeah, thank you.
There is one hand up. Daniel?
Hi, I was just wondering, you mentioned the gate theory. Is use of capsaicin cream, is that related to that for neuropathic pain, or is it a different mechanism?
Yeah, no, that's slightly different. I mean, that's, to be honest, it's partly related. It doesn't really activate the descending pathway as such, but it does activate other receptors where it works a bit like your opioids. So, you know, you've got, it's related to release of endorphins and things like that within the body. So it's got specific opioid receptors that they act on, which does interlink, once again, like all things in the central nervous system do, with the gate control pathways, but it doesn't directly activate either the PAG pathway or the interneurons within the spinal cord. So it's not quite a direct activation of the system. But as you've noticed in many of the talks of the last few weeks, you know, every part of the brain, every part of the spinal cord actually interacts with each other constantly. So it's a bit difficult to say it doesn't activate it, because it does to a certain extent. I'm not sure that actually answers your question.
Thanks for the great lecture. Thank you.
Great. Well, I shall leave you guys to it if you have no further questions.
Thank you, Mr. Tsang.
Yeah, thank you. Thank you very much for joining.